Welcome. Thank you for joining us today. I'm Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
And my name is Stephanie, and I'm a public health intern here at the Blum Center.
Before I get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has muted so you can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you if it's complete. Your feedback is important to us as we plan future programs. All right, so next I'm going to turn over to Stephanie, who will introduce today's guest speaker.
Thank you, Amy. So today, joining us, we have Dr. Jan Shifren. Dr. Shifren is a reproductive endocrinologist and director of the Mass General Midlife Women's Health Center within the Department of Obstetrics and Gynecology at Massachusetts General Hospital. She is also the Vincent Trustees Professor of Obstetrics, Gynecology, and Reproductive Biology at Harvard Medical School. Dr. Shifren cares for women with infertility and later in life with concerns related to menopause. She enjoys teaching about menopause and conducts research to advance midlife women's health and quality of life. She's here today to give a talk on managing menopausal symptoms. Please join us in welcoming Dr. Shifren.
Thanks so much for those lovely introductions. Let's see if I can minimize that. Terrific. So welcome everyone. As you just heard, there will be time at the end for your questions. So please do start entering questions in the chat now. Whenever you have a question, just type it in, and then we will definitely leave some time at the end to review them. So absolute pleasure to be here this afternoon to share with you a discussion about managing menopausal symptoms. See if I can get that to move forward. There we go. So I did want to note that although I have no financial disclosures, in this presentation I will typically use the word woman, but wish to acknowledge that many people experience midlife symptoms with a wide range of gender identities, hormones, and anatomy. And the research findings and treatment options discussed generally will be relevant to most people with midlife symptoms.
Dr. Shifren,
Yes.
do you mind sharing your slides? We don't see it on our end.
Oh my goodness. I'm glad you said that because I was shared and then you guys shared and maybe something happened there. So let's try again. Can you see them now? No?
Perfect.
Ah, wonderful. Terrific. Okay. Sorry about that, everyone. So I'll just go back one. Well, I guess we can just keep moving forward. Terrific. So why is understanding menopausal symptoms important? Clearly, because they're really bothersome. But most importantly, we are really fortunate in the developed world that women can anticipate spending a third of their lives beyond menopause. And that's because the age of menopause has stayed remarkably constant over 150 years that it's been tracked at about 50-51. And yet we are so fortunate that women are now living until their mid-80s. And so that does mean that both the symptoms and the health conditions that affect us after menopause are really important. And so although we'll be speaking about symptoms today, this is also a really good time when women come to see me, let's say at 51 with bothersome hot flashes. Of course, we want to address the symptoms. But I also want women to step back and think, how can I make the next third of my life as healthy as possible? There are so many great educational programs in the Blum Center, so I do encourage you to take advantage of them. But of course, you want to think about this as a really good time to keep your bones strong, right? So, regular weight-bearing exercise. Walking is great weight-bearing exercise. Adequate calcium and vitamin D. Ideally, think about getting that in your diet. This is a good time to think about, of course, cancer screening. I know Blum has a lot of terrific programs on that. Things like if you are over 45, making sure you've had that first screening colonoscopy, breast cancer screening, depending on your risk factors. Cervical cancer screening becomes even less important as we get older, but still something to keep in mind. So, good time to think about bone health, cancer screening, and most importantly, heart health. So, really important time to make sure that you've got the healthy weight, healthy diet, controlling risk factors like high blood pressure, high cholesterol, and trying to get that daily exercise if you can. Really keep that step counter on and stay active. So that's just a little background about staying healthy after midlife, but we'll really be talking about symptoms today. So what are those symptoms? We typically really focus on hot flashes and vaginal dryness. Those are the classic estrogen deficiency symptoms that women experience at midlife. But women come in with a host of concerns at this time of life, including disrupted sleep, painful sex, mood changes, including depression, anxiety, weight gain, fatigue, low libido, brain fog, cognitive changes, and of course, that kind of insomnia fatigue. So, in general, what I typically do is encourage women to focus on treating the principal symptoms of hot flashes and vaginal dryness. And often, once those classic estrogen deficiency symptoms are treated, so many of the other things get better. So I am what we call a domino hypothesis believer. And clearly, if you're having bothersome hot flashes and night sweats and you're not sleeping well, then you know what? You're going to have mood changes. You're going to be more irritable, maybe more blue. You'll have more trouble remembering where you left your keys or, what you needed to do that afternoon. And you may have lower libido because you're just more tired and grumpier. So really focusing on sleep. And then, of course, things like sex is more pleasurable when it's not dry and uncomfortable. So kind of focus on those estrogen deficiency symptoms, with your healthcare professionals, and a lot of the other stuff does fall into line. I do always share with women that unfortunately we all gain weight after midlife. Even people, those rare, fortunate people who didn't have much trouble before midlife will often experience all of a sudden that despite eating the same, exercising the same, they're gaining weight. And we also see a shift to kind of that apple shape with more weight gain around the middle. And that we think is pretty universal. It has to do with metabolic changes of both aging and menopause. Hormone therapy in particular doesn't make that better or worse, but it is something that most women experience. And so it is an important time. I had a patient who said it best. You have to run to stay in place. So typically doing everything you used to do in the past may not be enough. Time to, bump up that exercise and maybe even more healthily. So that's just a little overview about some of the other things that happen at midlife. But we'll really be focusing first on hot flashes. The formal name for that is what we call vasomotor symptoms, and that incorporates both hot flashes and night sweats. Night sweats are basically hot flashes that happen at night. Whether you sweat or not, they still can be very disruptive. So how prevalent are they? They are very common. These colors, the orange represents the very lucky women who really experience no hot flashes. And that is if we look at the peak of the hot flash experience, which is really that year of the last menstrual period, you can see the majority of women are experiencing at least some hot flashes or night sweats, about 75% of them. If we look at the red and the green, those are the really bothersome hot flashes. That's up to 50% of women. So, this really is a symptom that affects a lot of women. How long do they last? Important to realize they can start even in the early menopause transition, long before, even in the early 40s when women aren't really thinking about menopause. And for some unlucky women, they can last more than 10 years. A lot of women are very lucky, more fortunate, they'll just last a year or two or three. But there are definitely some women for whom they last a really long time. We think a lot of this is predicted by genetics. Knowing your mom's menopause experience may be a little helpful, but, every woman is different. I realize we haven't actually defined menopause. So menopause is officially defined as 1 year beyond the last menstrual period. And so it's a funny diagnosis because you don't know you were menopausal till a year after you were menopausal. But essentially, if you haven't had bleeding for a year, you can look back and say, I was menopausal a year ago. To be honest, the actual date of menopause is not that important, as long as it's in that normal range, which is typically anywhere from 45 to 55. If it's early, we're more concerned. There may be more health implications. If it's much later, there may be some other impacts on health. But, as long as it's in that age range, the actual date doesn't really matter. We really want to treat symptoms when they occur, when they're bothersome. And it doesn't really matter whether you're perimenopausal, which is that time leading up to the final menstrual period, or postmenopausal. What we really care about is optimizing health and quality of life with this midlife transition. So hope that's helpful. For some women who may have had their uterus removed or may be on medications that prevent them from having periods, like a progestogen IUD, they may not actually even know when that last period occurred. And again, the most important thing is that we manage symptoms, not the actual age of menopause, which most typically is around 51, but with a very wide range. Hope that's helpful. So I did want to talk even a little bit more about perimenopause. That is that time leading up to menopause. And what I often say is menopause in of itself is much more straightforward than perimenopause. Typically, if you're no longer having bleeding, you'll either have symptoms or not, and we treat them. But the really tricky time can be up to 10 years. For most women, it's just a few years leading up to that final menstrual period, when there's some months you're ovulating, and you'll have a very typical cycle. You make estrogen for most of the month, you make progesterone after ovulation, you have a regular withdrawal bleed, typical flow, typical duration, and you don't have hot flashes or night sweats. But then what happens in the perimenopause is some months you ovulate and you have that pretty typical cycle. And then all of a sudden, you may not ovulate for a month or two. And that's the chaos here. And during that time, all of a sudden, you may experience hot flashes, night sweats, vaginal dryness, irritability because you're not sleeping, brain fog because you're not sleeping. And then all of a sudden, the periods come back. It's very unpredictable. And that's, I think, also adds to the stress. What we also see during this time period is that even though you're not ovulating and you regularly, sometimes the ovaries are still making estrogen, but they're not making the progesterone that protects the lining of the uterus from the estrogen. And so all of a sudden you haven't bled for 3 months and you're soaking through your clothing. Really disruptive, very stressful. So as far as the bleeding of perimenopause, if the periods are just spacing out, you're lucky, that's what we expect. But if at any point you start having very frequent bleeding episodes, like 2 in 1 month, very heavy bleeding, soaking pads, or periods that last a really long time, like it felt like a normal period, but all of a sudden you're at day 10, 12, 14. Those are really the 3 bleeding changes that should alert you to contact your healthcare professional. You may contact your primary care physician first. They may refer you to gynecology if they have concerns. Sometimes we do an ultrasound. There's other ways we evaluate it. So, the bleeding is kind of the most obvious symptom that you're in the menopause transition, as are the hot flashes. But there can be more subtle changes as well. So hope that was clear about kind of how to assess bleeding. I do encourage women, as soon as they start having funky periods, to keep a calendar. There's a lot of online calendars if you like those. I'm so old-fashioned, I still remember the days we handed out paper calendars, but that can be very helpful for kind of tracking where you are. No matter how many blood tests we have, they're not really that helpful. At the end of the day, knowing what's happening with your periods is the best predictor of when you will actually go through menopause. The longer the gaps between periods, the closer you are to your final menstrual period. Now, there are some women who have month, nothing. And then go a year and they know they were menopausal. That's very convenient. That's very rare. What's much more typical is this kind of several years of complexity and variability, and then that last period. So how can we stay cool? Let's go back to hot flashes. And most women have figured this out on their own, but staying cool really does appear to help. So things like light layered clothing, cotton and wool on the bed, stay away from down, cotton night clothes, sheets, pajamas, those things can really help. inexpensive, bedside fans. Some people who are at a desk will just keep a fan blowing at their legs if they don't have that much control over the temperature in the office or room. AC can really help. So staying cool does appear to help. Other things that can be helpful but may not be better than what we call kind of placebo would include acupuncture. So I have a lot of patients who say their acupuncture really helps. We've even done some studies to show it can be helpful. The traditional Chinese medicine acupuncture may really be no more helpful than what we call sham acupuncture with shallow needles. But at the end of the day, if it reduces your hot flashes 30%, that's what we saw in this study. Does it really matter if it's traditional or sham acupuncture? Important thing with acupuncture, it can be expensive. But most importantly, just make sure to use a certified acupuncturist with sterile disposable needles. And in that setting, it's very safe. If you find it helpful, relaxing, reduces symptoms or reduces the bother associated with those hot flashes, terrific. The other thing in that category, a lot of people ask, well, what about dietary changes? Soy, there's a lot of products over the counter, red clover. And at the end of the day, the good news is almost anything that you try for hot flashes will reduce them about 30%, and that may be all you need. When we really look at careful trials where we use placebos or kind of sugar pills with the soy products, it ends up that a lot of these products are no more effective than a placebo. On the other hand, what I always say is as long as you're informed, it's evidence-based, if that over-the-counter soy product is really giving you the benefit you need, as long as it's not too expensive, it's likely to be, fine to use and safe. With over-the-counter products, as we always say, they are not carefully regulated by the government. So do look at the package. It should say good manufacturing practices, and also do, of course, make sure it's made in the United States. Don't use any little herbs that are shipped over from, somewhere in Asia where you have no idea whether they're exposed to pesticides and other things. Do be careful about what you ingest. But, if it's Whole Foods or CVS or Walgreens and it's made in the United States, it's likely to be safe. If it's not effective, don't keep spending your money. All right. So what about things that are more effective than sham treatments or placebos or just staying cool? If you either choose not to take menopausal hormone therapy or for various reasons really can't take hormones, the SSRIs, SNRIs, those are the medications that we use that are government approved to treat depression. You may have heard of things like Paxil or Prozac or Lexapro. Those are some of the trade names. The good news is those also reduce hot flashes in what we call randomized controlled trials with a sugar pill, with a placebo. They decrease both the frequency and the severity of hot flashes. Not as effective in general as menopausal hormone therapy, but again, for people who choose not or shouldn't take hormones, these are typically well tolerated and do improve the hot flashes. There is one form of a very low dose of Paxil or paroxetine, which is actually government approved to treat hot flashes. All of the other ones would be considered off-label, but again, we have very high-quality studies showing us that they do work better than placebo, so it's definitely an option. Very recently, just about a year ago, we had approved by the government the first truly effective non-hormonal treatment for hot flashes. This is really exciting. Many of us feel like this has been a real game changer, especially for our patients who really can't take menopausal hormone therapy, and that's principally women with breast cancer. That's probably the largest group of women who can be really symptomatic at midlife, and yet the data are concerning that they should not use estrogen. And so this is a really interesting class of drugs. What's exciting is that it also helped kind of prove where hot flashes take place. We assume they take place in the hypothalamus, which is kind of, we call it the master gland up in the brain, but no one knew the exact mechanism. And so some really smart scientists figured out that there are these neurons called Candy neurons, KNDY. Interestingly, these are the same neurons that are responsible for puberty, to kind of get everything going at puberty. They're also the same neurons that are really important every month to get the regular menstrual cycle. So it shouldn't be really surprising that these neurons are involved with some of the complexities of menopause. what we think is that these neurons are kind of on overdrive after menopause because they're trying to push the ovary to make estrogen, but the ovary is menopausal. It can no longer make estrogen, but the brain doesn't know that. And so that these neurons on overdrive interact with what are called heat sensing neurons, and that hot flashes are almost a byproduct of the brain working really hard to try to get a woman to ovulate. So some, again, really thoughtful scientists designed some drugs that prevent these candy neurons from doing their thing and from connecting to the heat sensing neurons. Very dramatic reductions in hot flashes. You can see here both severity and frequency. And women who take these drugs will notice improvements within a week. So can be incredibly helpful. You know, they don't work for everyone, but it's very exciting. This is the first drug to be approved in this class. There's another one already sitting at the FDA that might be even more effective. You know, every drug has some risks and side effects. If you're in this group of people who really can't take hormones, and of course, speak with your healthcare professional about this kind of exciting new drug. Its real name is fezolinetant. The name that you'll see advertised, its trade name is called Veozah. And it is exciting to have these drugs available now. Well, we've talked a little bit already about menopausal hormone therapy. It is a very effective treatment for menopausal hot flashes. And at the end of the day, we really do feel it is the mainstay of treatment for otherwise healthy people, especially people under 60 with bothersome hot flashes. I should just say that, you know, there's a lot of buzz about menopausal estrogens. I've been around long enough that I've seen a time when everyone was taking them. I mean, not everyone, but, you know, in the 1980s, 70s, they were very popular. Then after a large study that I'll review with you in 2002, everyone panicked and use declined, and now we're starting to see a little bit of a pendulum shift towards their being used more. And so that's a good thing because we want women who are good candidates for menopausal hormone therapy, who are healthy with bothersome hot flashes, to get the treatment they need. On the other hand, I'm a little bit concerned that the pendulum is swinging a little bit too far, and all of a sudden we're back to, you know, hormones should be in the water, everyone should take them. If you're not taking them, you won't be healthy. That's not true either. So hopefully after some discussion today, we'll kind of get back to that terrific place in the middle where people with bothersome symptoms who are healthy can get the treatments they need, and people who are aging well without bothersome hot flashes and night sweats don't need to take hormone therapy to stay healthy. Right now, we're talking about something called systemic estrogen therapy or hormone therapy. That's when you take hormones in high enough doses to raise blood levels, because they have to get to the brain to tell the brain to stop having hot flashes. In a few minutes, I'll also talk about really low doses of estrogen that are placed directly in the vagina for vaginal dryness. That's completely different in terms of risks and benefits, and I'll go over that in a minute. But a lot to think about today. Higher doses of hormones that are great for hot flashes, but do have some risks. We'll talk about those. That's very different from the really low doses of typically estradiol that you can put directly in the vagina for dryness. And that's really almost anyone can use that because it doesn't raise blood levels. So back to systemic hormone therapy that raises blood levels, treats hot flashes. So this is kind of a classic study of one form of hormone therapy. Women who don't have a uterus, so if you've had a hysterectomy, you would take just estrogen alone. If you have a uterus, and that's most women, then you need to do kind of what nature did during the reproductive years. You need to take estrogen with a progestogen. That progestogen protects the uterus from overgrowth. So 2 hormones if you have a uterus, 1 if you don't. What you can see is here's placebo. So that's the sugar pill. And again, as we expect, it reduces hot flashes about 30%. But what you can see is that the estrogen or the estrogen progestogen therapy is much more effective than the placebo. Really works very well. Well, this is, I thought, a pretty wonderful, it was actually a great article. If you haven't read it, I bet you can get it online in the New York Times Magazine that really raised everyone's alert that, hey, maybe that pendulum swung too far. We were too concerned about risks, or the risks weren't really being shared in a really accurate way. And so a lot of symptomatic women were not getting treatment that they would have benefited from. And so I think that's what they meant with misled about menopause. Not that hormones should be for everyone, but that women who are symptomatic really do deserve relief of their symptoms. And for most, again, women with bothersome symptoms who are healthy under 60, this will be a terrific option. It was a great article and very thoughtfully written. So feel free to pick it up if you find it. So what are the data about some risks and other benefits? So before what we call the Women's Health Initiative study, that was the one that was released in 2002 that really got this pendulum swinging in the other direction. Before that, we had what are called observational studies that women who took menopausal hormone therapy actually had a lower risk of heart disease. That would be very exciting, right? You could take a hormone therapy that treated your hot flashes, your vaginal dryness. We actually already know it's pretty good for bone density and fractures. And oh my goodness, wow, it could also reduce heart disease risk. And that would be very exciting because as we talked about a little in the beginning, heart disease is, the #1 cause of death for most women in the developed world. So these data were very exciting and they show that wow, women on hormones could have up to a 50% reduction in the risk of heart disease. What's really important to realize, though, is this is what's called an observational study. So this is where researchers look at women who chose to take hormones when they reached menopause. So there are things called confounding factors when we look at observational studies, because basically women who choose to take hormones aren't the same as every other person. And we actually knew that. Women who chose to take hormones back in the 70s and early 80s, they were healthier. By definition, if you take a medication, you got to see a healthcare provider. They were seeing their healthcare professionals regularly. They were actually, even before menopause, healthier body mass indexes, they were healthier weight, they exercised more, they were less likely to smoke. So basically, a healthier group of women just happened to be the group of women who are more likely in the 70s and 80s to take hormones. So we think a lot of this, quote, benefit is because they were healthier people. So the NIH decided to really study whether menopausal hormones could be used basically to prevent the diseases of aging, whether they could be used to reduce the risk of heart disease. That was really the principal outcome that the investigators were looking at. It's really important to realize that this Women's Health Initiative study, and I will talk about a lot because it's so important in how we've thought about hormones in the world, not just in this country over the past 20 years. It's really important to realize this study was not designed to see whether hormone therapy was beneficial and safe for healthy women in their early 50s with bothersome hot flashes. The average age of women in the study was in their mid 60s, and these were women who did not have hot flashes and were usually, many years beyond menopause. And even if they'd taken estrogens, were many years beyond that. So this is a group of women where really the investigators were looking at whether you could prevent the disease of aging by starting hormones in the 60s and seeing if then women could be healthier. So what did this study show? I don't need to tell you that bad news sells newspapers and good news doesn't. And so do be careful. Most of us, even healthcare professionals, get a lot of our medical information from the front page of the Globe or the New York Times. Bad news sells papers. So basically what the study showed when they first broke, there was double blind, meaning there was placebos. It was randomized to treatment versus placebo. And after about 5 years, they stopped the study a little earlier than they anticipated because it did not look like hormone therapy should be a good treatment to prevent the disease of aging. What they saw was that actually that rather than protect against heart disease, there was actually a slight increased risk of heart disease in the women who were randomized in this control trial to take it was an oral estrogen pill. They had a uterus. This was the first study stopped. So they were taking estrogen and a progestogen. Now, this increase in heart disease was what we call a relative risk of 1.3. That's actually not a really high risk. That's probably less than hypertension or high cholesterol untreated, but it certainly means we shouldn't be using hormones to prevent heart disease. But of course, on the front page of the Globe, everyone thought, oh my goodness, I have a 30% chance of dropping dead of a heart attack tomorrow. So everyone stopped hormones. There was a lot of chaos. Healthcare professionals were no longer educated about how to safely use hormones. And, over the past 2 decades, a lot of women did suffer, and I'll show you why. There was also a slight increased risk of stroke. So there are real risks, but given other things, for many women, benefits might still outweigh risks. There was a slight increased risk of breast cancer seen in the Women's Health Initiative. This was actually seen in all the observational studies as well. So basically, menopausal hormone therapy, if taken for more than 4 to 5 years in women with a uterus taking estrogen with a progestogen, is associated with a slight but real increase in the risk of breast cancer. Again, a relative risk of 1.3 is about the same as other risk factors for breast cancer, like obesity or having more than one alcoholic beverage every day. So this is a real risk, meaning that's why you wouldn't want to take hormones because of skin or hair, but it's a risk that might be very acceptable if you're 51 and having 4 hot flashes every night. So acceptable risk. And here again, with the breast cancer risk, if women come off their hormones within 4 to 5 years, the randomized trials and the observational studies would show us that they won't be seeing that increased bump in breast cancer risk. So short-term use looks safe. So that's what we kind of had in 2002. Now, a very important study was published 5 years later in 2007. This is the same Women's Health Initiative study. I've had people say, well, what about the new study? It's actually a really old study, but people are finally looking back at data that was published many years ago and saying, oh, actually, I guess for a healthy 50-year-old with hot flashes, benefits probably do outweigh the risks. So same data, but people are at least looking, we are happy to say, are looking at it more carefully. So this study published in 2007, what you can see is this is now dividing up that study I showed you by age. And this is the number of additional cases over placebo of bad outcomes. This is per 10,000 person years. So this is 10,000 people over a year. You would see in the 70 to 80-year-olds a lot of bad events, heart disease and stroke and death. So, this is not a good treatment for older people. And 60 to 69, there was certainly global indexes, kind of bad things put together, balanced against good things put together. Good things might be a hip fracture reduction. A bad thing might be a leg or lung cut, a stroke, a breast cancer event. And so, for women 60 to 70, there were certainly more events or more than 10 years beyond menopause. But this is the group I want you to focus on. The majority of women with bothersome hot flashes that we've been treating with hormones for a long time, who got panicked and weren't taking hormones after WHI, are typically in this age group. And in this age group, things looked really good. They had, if anything, a little bit less heart disease and death. Now, we're not prescribing hormones to people in their 50s to reduce heart disease risk, but we're prescribing it if they have bothersome hot flashes, and we're not worried that, a healthy person in their 50s is all of a sudden going to have a heart attack or stroke. It would be very rare. I hope that's helpful. It's a really complicated study, but really important. What are some of the things that predict the likelihood that you'll have a bad outcome if you take hormones? As I just showed you, age. If you're under 60, things can look pretty good. And if you're within 10 years of menopause. Now, if you happen to be a 52-year-old, but you have high cholesterol and you're not taking your statin and it's pretty high, if you have something called metabolic syndrome, which is a combination of glucose intolerance or tendency to diabetes, as well as some obesity and elevated BMI, often associated with some adverse changes in your lipids, not a good candidate. And of course, if you're at high underlying heart disease risk, clearly anyone who's had a heart attack, who has angina, not a good candidate. But if you're healthy, especially if you're healthy under 60 and within 10 years of menopause, if you have bothersome hot flashes, benefits are going to outweigh the risks. And I think that's really the way we should be interpreting the Women's Health Initiative trial, which is the same trial that caused so much panic 20 years ago. There are also other ways we can change the formulation of menopausal hormone therapy that might make it safer. So, for instance, we typically encourage people to think about using their menopausal estrogen as a skin patch or as a skin gel, because there are what we call observational data, and you know just what that is. That's not a randomized trial, but when we look at women who choose to take their hormones by patch instead of pill, we don't see the same bump in leg and lung clots that we see when women swallow postmenopausal estrogen pills. We also, in some studies, see a slightly lower risk of things like stroke. So if you have no strong preference for a pill and you're menopausal with bothersome hot flashes, you know, your healthcare professional may really encourage you to think about using the patch. Is the easiest. It's generic. It's not that expensive. You put it on the skin of your low belly. I like one that you change twice a week because it doesn't get too gluey and it sticks really well. And it comes in lots of doses. So you can use the lowest dose that treats hot flashes and slowly come down over time. Even though there aren't randomized studies that weaning hormones is better than stopping cold turkey in clinical practice, we have women who are doing well, come off very slowly over several years. And typically, most of the time, the hot flashes don't come back. So, what are the absolute, what we call contraindications, the absolute reasons you can't use hormones: heart disease, stroke, leg or lung clot, breast cancer, endometrial cancer. And of course, if you're having bleeding and it hasn't been evaluated, you shouldn't start hormones till it's been evaluated. Now, what are the relative contraindications? Those are all the things that might put you at high risk for the absolute contraindications. So for instance, you know, if you've had a breast biopsy that shows atypical ductal hyperplasia, you don't have cancer, but unfortunately, you're at high risk for cancer. You might go on hormones if you have terrible hot flashes and nothing else is working. But now that we have the fezolinetant, I'm kind of encouraging people at really high risk to think about trying that first. Maybe we can talk a little more if we have time during Q&A. Biggest drawback to the Veoza for these patients who really shouldn't take hormones is that it's very expensive. But you know, your healthcare professional, we write letters. For most of our patients, we've been able to get it covered. And then there are copay plans online that can really help. So the other big topic I want to talk about is vaginal dryness. This is very common as women age. Often, a lot of women think, oh, I'm beyond hot flashes, I'm 60, I'm doing really well. Oh, the vaginal dryness will get better too. But unfortunately, the hot flashes get better, the sleep disruption gets better, the vaginal dryness gets worse. So the more years you are of estrogen deficiency, the worse it gets. Unfortunately, this is really undertreated all over the world, and we think that's often because women think it's a natural part of aging, or they're worried about risks, and they just don't talk to their healthcare professionals. And unfortunately, a lot of healthcare professionals don't also realize how prevalent it is, how many terrific treatments we have, and they don't bring it up and ask. So it's both sides. What we know is that, you know, for people who are sexually active, whether it's female partner, male partner, no partner, sexual activity can be really adversely affected by vaginal dryness, right? Anything that's uncomfortable, that will lead to lower libido, lower interest, and then that can be a really vicious cycle. A lot of times people first start with just over-the-counter things that can really work well. There are lubricants. Those are designed specifically for penetrative sexual activity, intercourse with a male partner, other kinds of penetrative activity with a same-sex partner. Though they do really reduce friction and can make a very big difference. There's so many over-the-counter. I typically recommend people to try a few different brands, see what one they like. In general, avoid things with perfumes and scents and colors and tingling and zesty. They tend to have a lot of chemicals, additives. Keep it pretty simple. One that a lot of my patients like is a silicone-based one called Astroglide, but I'm not here to market any specific products. There's lots of great things out there. Try what you know, try a few, see what you like. Another whole class of products are called moisturizers, and those are not designed to be used directly with sexual activity. Those are designed to be used on a regular basis, just like the way you moisturize your hands and face, you know, potentially every day. For instance, again, I'm not selling any products. I often hesitate to use brand names in any kind of educational activity, but there's lots out there. Try different ones, but one that's very popular is called Replens. And again, these are non-hormonal, no prescription. You can get them at any of your favorite drugstore. And this you typically use on a regular basis, like Monday, Wednesday, Friday. Often put it in the morning. It says nights here, but if you put it in the morning as you walk around, it kind of lines the walls of the vagina, sticks a little bit. It has bioadhesive properties. There's a lot of them out there. A lot of people want to do things really naturally and very inexpensive. You can use natural oils. I always learn from my patients, and I have patients who use olive oil and baby oil or all sorts of, safe oils, coconut oil, whatever you may like, both for a moisturizer and with sexual activity. Only drawback there is that it can be a little messy, but very inexpensive, and a lot of people like that. And be a little careful. Most people, so a few people can get some like little pimples in the vagina from the oils, but most people do really well. So lots of options to start with. Also want to remind people that the pelvic floor is really important in terms of having comfortable sexual activity at all times, including menopause. There are times when we have patients we refer to pelvic PT. They may need to use dilators or do pelvic floor exercises to keep sex comfortable. So it's two things. Have the vagina, the lining of the vagina should be healthy, but then also the pelvic floor might need some work. I really do want to discourage things like laser, incredibly expensive, not government approved for anything to do with vaginal health. Sham laser works very well. So even though there are some studies that show it can help with vaginal dryness, when some really thoughtful investigators did real laser, but also put the laser in, had it shake and buzz, but not give laser energy, those people also got better. I mean, when we want to get better, the good news is we often do, but I would advise staying away from it. Very expensive, and there are also potential risks. Really, the mainstay of treatment for vaginal dryness, especially once lubricants and moisturizers aren't doing the trick, or if they never help, low-dose vaginal estrogen. There's a term called bioidentical or natural. I do like to let people know that's actually a marketing term, not a medical term. But most people, when they say that, what they mean is, I'm going to use the same hormones my body made when I was cycling. And that would be estradiol and progesterone. So there is, if you're using systemic hormones for hot flashes, we have a lot of bioidentical or natural FDA-approved estradiol and progesterone products, if that's your preference. But when we use vaginal estrogens, almost all of them are estradiol. Almost all are kind of natural. But again, natural doesn't mean safer or more effective. It just means it is estradiol, the same hormone your ovaries made when you were cycling. One thing I should just say before I forget, please do not use compounded hormones. People are like, oh, this is bioidentical, it's natural, it's so much safer. You can use bioidentical natural, but they should be FDA government approved natural hormones. And that's because they have a whole level of oversight, very careful to make sure that there aren't contaminants, that the dosing is the same in every dose you take, that it's absorbed well. There's a huge multi-billion-dollar industry with, I'm going to custom compound your hormones and there'll be no risks. Just because it doesn't come with a package insert, and no compounded products do, does not mean they're safer. It just means you're not being informed. So again, if you're with your healthcare professional, feel free to say, hey, I have a preference for natural hormones, but go for natural FDA government approved estradiol and progesterone in that setting. So for low-dose vaginal estradiol, there are these inserts that you basically put in twice a week. There's a little tablet with an applicator you put in twice a week. There's a terrific ring that you can put in for 3 months, change it 4 times a year. You just pull it out, put it in again. And there are creams that typically go in 2 to 3 times a week with an applicator. You can also put a little on the outside. They all work. They all work well. They're all very safe because it's very small amounts that don't raise blood levels. But I often encourage people to try a few different, this you need a prescription for, speak with your healthcare professional. But I do typically encourage people to try a few different products, see which one they like best. And again, there's really no end date for these. What I tell women is that vaginal dryness will usually come back once you stop. It gets worse with aging. If you're doing well, you can use it for as long as you care about vaginal dryness. The only important thing is report any bleeding, even spotting after menopause, to your healthcare professional. And that should be whether you're using low-dose vaginal estrogens, systemic estrogens, or no hormone therapy. Any postmenopausal bleeding, even spotting, even after sexual activity, should be reported for evaluation. All right. So this is just to show you that basically the blood levels with all the products I just showed you are pretty much the same as if you didn't take estrogen after menopause. So that's very reassuring. And what that means is that basically everyone can use it, even people who have a history of breast cancer. Speak with your oncologist, try other things first, but if you really need it, most people with breast cancer can safely use low-dose vaginal estrogen therapy. If you've had heart disease or a stroke or a leg and lung clot, you're still a candidate for these microdoses of estradiol in the vagina if needed. And again, do speak with your cardiologist, with your oncologist, make sure the whole team is on board. I do like to warn women, you will see the exact same very frightening package insert with these microdoses of estradiol in the vagina that you see with systemic estrogen therapy. As we just discussed, all of these risks are seen in the randomized trials of systemic hormone therapy, but might again be not that relevant for healthy people under 60, but these are still the real risks of systemic hormone therapy from the trials we have. These are not relevant to the microdoses of estradiol, but we've tried. We can't seem to get the FDA to change this insert. So, be informed about medications, but if you're using microdose estradiol in the vagina, this is kind of the one time I tell patients, don't read the package insert. Again, probably should be quite safe. The only women who we are especially concerned about with low-dose vaginal estrogens, if you're in this audience, you have breast cancer, you're on an aromatase inhibitor, those are the few patients we really want to try other things as much as they can. And that's because the role of that drug is to make your estrogen levels even lower than menopausal levels. So if these products keep the estrogen levels menopausal, you're no longer getting that benefit with the AI, maybe. But some patients with AI speak with their oncologist and might just use the estrogen shorter term. Okay, so please be careful about where you get your information. The Blum Center is a great place. Please also Google MGH Midlife Center. MGH Midlife, that will bring up our website. We have a conference every year for the community with 4 terrific speakers about all sorts of topics. And then we put those videos on the website. We actually just posted the ones from this year's conference. We had 800 registrants for the conference. There's a lot of, people really want to be healthy at midlife. And they're all the topics from past conferences. They're very short videos. They're really fun to watch. So Google MGH Midlife, share it with your friends, check out the videos. But do be careful about the websites you use. Here are some particularly good ones. Most importantly, choose .orgs. I should have written .edu here. I better update that. .orgs, .edus. Do avoid .coms. The moment you're on a website and they start to sell you something, close the website, go somewhere else. If it's an educational website, they shouldn't be selling you anything. And if they start using terms like anti-aging, just get off the website, right? Anti-aging is mostly lots of exercise, healthy diet, healthy weight, good social interactions, keeping active and busy, community. You don't need, some very expensive product for that. How's that? So this is also terrific. If you Google menopause.org, this is our Menopause Society website. Everything on here, they won't sell you anything, and everything on here is very accurate. There are these wonderful things called Meno Notes. And the ones we talked about today, there's ones on hot flashes, vaginal dryness, and hormone therapy, but they also have ones on sleep. This is where they discuss the risks of compounding, bleeding. So definitely just Google Menonote vaginal dryness. It will pop up for you. Share it with your friends. So I think we're at the end of the more formal presentations. It looks like there's lots of questions in the chat. Yeah, so I will, so we can just start doing those questions. How's that?
Sure. All right. So we got a lot of questions, and thank you, Dr. Shifren, for your presentation today. And if we go past 1 o'clock, is it okay to still do questions, or do you want to cut off right at 1?
You know what? It's fine. And you know what I just realized? If it's okay with you, Stephanie and Amy, I can actually see the chat. So sometimes it's easier for me to pull a few questions together and kind of prioritize. So let me take a quick peek. Thanks for all those nice welcomes. Okay. Excellent question. So people may have heard that, typically in the old days, to reduce the risk of ovarian cancer, if you might have had your ovaries removed. And there are risks to that too, but especially for people of a genetic predisposition to ovarian cancer. Often once they're done with their family building, typically once they're around 40, we often remove the ovaries or we discuss it. It's a hard decision. And then those women often go on menopausal hormones to prevent the risk of estrogen deficiency at a young age. But now there's some interest in just removing the tubes. It hasn't been proven that it's as protective as removing ovaries. But let's say you're having your uterus removed for fibroids. Your gynecologist might say, hey, we can remove the tubes at the same time. Can't promise that will reduce your risk of ovarian cancer, but since it doesn't really affect the hormones the way removing the ovaries does, maybe you should consider it. So the question is, can that influence the age of menopause? And unfortunately, it can. It's not the same as removing the ovaries where you're menopausal the moment you wake up from surgery. But it can affect the blood supply to the ovaries. Any surgery can, even a hysterectomy when we leave the tubes. Women often do go through menopause a little bit earlier. So really interesting question, but let's say you had your tubes removed and now you're a little surprised because your menopause seems to be a little earlier than your friends. It may be related. May have still absolutely been the right decision when we weighed risks and benefits, but yes, it happens. So someone says, I haven't had a period in a year and a half, and I'm going to be 52 in June. Is it too late? So if you are having bothersome hot flashes and you're healthy, no, it is not too late. And you should seek care with your healthcare professionals. Yeah, again, this pendulum has been really a problem. It was too far, everyone was on hormones in the 80s, even when they maybe didn't need them. Then no one was on hormones after the Women's Health Initiative was launched in 2002, despite the fact by 2007, we really could see that for younger, healthier people closer to menopause with symptoms, the benefits would outweigh the risks. That message didn't really get out. And all of a sudden that message is getting out, which is good. But the message now is, oh my goodness, you won't be healthy unless you're on hormones. And they have all sorts of other benefits, As I say, if someone tells you that menopausal hormone therapy will give you, perfect moods, perfect sleep, a great sex life, all the energy in the world, perfect hair and skin, if it's too good to be true, it's too good to be true with no risks, right? So, do take information thoughtfully, which most of you already do, or you wouldn't be at the Blum. All right, what treatment would be best to help with sleep and a little brain fog? So I'm glad you put those two together because most people, when they're sleeping well, the brain fog gets better. Sleep hygiene is really important. I mean, definitely speak with your healthcare professional. There are lots of medications that can help with sleep if you need medications. Sleep is really important. On the other hand, people who really work hard on sleep hygiene do a great job. There's a wonderful website by the VA. I learned about this at a conference. It's called Pathway to Better Sleep. So if you Google Veterans Affairs, Pathway to Better Sleep, it will bring up basically a program of cognitive behavioral therapy to improve your sleep. It starts with all of the things that we should do that we often don't, right? Use the bed only for sleeping and sex. Don't read in bed. Don't watch TV in bed. Take the electronics out of the room. Try to go to bed at the same time every night and wake up at the same time every morning, even if it's a weekend. I mean, vacations, that's really hard to do. But in general, that makes a big difference. And try not to get too anxious about your sleep. And that can be really hard, but that feeds the insomnia, meaning don't have a clock at the bedside. If you wake up, try to stay calm. Some people do relaxation response stuff. And then if you can't go back to sleep, the recommendation is that you have another place in the house, if you're lucky enough to have an extra space, where you've set up your night spot. And that's usually like a low reading light, some relatively, boring magazines, nice travel or cooking. Don't do political magazines. Don't do like an intense crime novel, just something really relaxing and just give yourself a little time. And then go back to bed when you're feeling sleepy. And if you get into bed and all of a sudden you're like, I'm not falling asleep, I'm getting anxious, don't lie there. You don't want your bed to be associated with, I can't fall asleep, I'm anxious. Get up, go back to your quiet spot, kind of train your brain. So there are a lot of data that cognitive behavioral therapy can be as effective as drugs. So typically recommend a lot of that healthy stuff. Some people, I have some patients who meditate. They wake up, they're anxious, they'll meditate, they'll do a little gentle yoga outside of the bedroom and then come back in. So whatever works for you. And then of course, if all of that stuff isn't helping, definitely check with your healthcare professional. And my hunch is there are some really effective medications. You may not need them long term. If it's hot flashes that are consistently waking up at night and you're healthy, then you may want to speak to your health care professional about hormones. But if it's not hot flashes, it's just that kind of midlife, I'm not sleeping as well, I'd usually try all those kind of CBT interventions first. Let's see. Oh, someone asked, yes, I think the recording will be available on the Blum site. So thank you. I think Amy already put that in. Let's see. So mom took estrogen during menopause, and then she had breast cancer. So I think, as I just shared, long-term menopausal hormone therapy, if you have a uterus and you're taking estrogen with a progestogen for more than 5 years, slightly increases the risk of breast cancer. So if your mom took hormones for 20 years, and a lot of people back then did, that is a risk factor. It's not why she got breast cancer, because a lot of people took hormones long-term. It's probably the combination of genetics, some lifestyle factors, and the menopausal hormone therapy is kind of another hit. Now, there are some data that women without a uterus who take estrogen alone, they may not have that same increased risk. It's probably still there, but not quite as dramatic. So if you've had your uterus removed, you may be, and you're having hot flashes. Again, if you're not having hot flashes, or there's no indication for systemic hormone therapy. You may still benefit from those really low doses in the vagina, of course, two separate things, but you don't need the higher doses. So let's see, how is hair loss on the head? So please Google MGH midlife and watch the video from this year's conference. One of the great MGH dermatologists, Sandy Zhao, did an amazing talk on hair loss. And so it is common with aging. So we associate with menopause, but hormones don't make it better. Hormones don't make it worse for most people. There's lots of other interventions. And so please watch that terrific presentation. Oh, can you use vaginal moisturizer and estradiol concurrently? Absolutely. So if you are using, let's say, one of these low-dose vaginal estradiol products, a little tablet twice a week, that may be really helping, but maybe not quite enough. You should still think about using lubricants. Most of my patients on low-dose vaginal estrogen still use lubricants with penetrative sexual activity, but you can also just add a vaginal moisturizer once or twice or 3 times a week. Those are incredibly safe, except for the cost. No reason not to use them. Great questions. Does vaginal odor change with menopause? Everything changes with both aging and menopause. If it's something that's really bothering you, especially if it's associated with discharge, check in with your healthcare professional. If it's, not bothersome, but you're just curious, wouldn't worry about it. In general, we really discourage things like douching and those feminine cleansing products. Just keep it simple. If there's anything uncomfortable or discharge, we kind of say soak and seal. And I'm taking this from Dr. Mitchell, who's our amazing gynecologist and vulvar specialist at the Mass General. Basically, just sit in some hot water, kind of like a sitz bath, which is basically just a little tub you put in the toilet, so you don't have to sit in the bathtub. Just sit in some, water that's comfortably hot, not too hot, but, warm, comfortable for just a few minutes. This is something you might have done for hemorrhoids, or if you had a baby after the stitches. Just soak a little bit, and then when you come out, pat things dry with a cotton towel, and then think about, you can seal a little bit. That could be, if you're having a lot of dryness or soreness, that can be done with just, remember, I always try to remind people the skin of the vulva, the outside, is just like the skin on your body. You can use any hypoallergenic moisturizer there, and a lot of people really benefit from that. So, again, I don't really want to use brand names, but you might have your favorite, Aveeno, Eucerin, Vaseline, petrolatum, things that are very hypoallergenic and emollient. Those are really good for help. Let's see. Someone brought up another brand, hyaluronic acid suppositories called Reverie. Again, that's in that whole brand of vaginal moisturizers, and they tend to be very safe. They're non-hormonal, they're over the counter. If it's helping you, great. If it's not, try something else. And again, the only drawback is sometimes expense. Let's see. Yes, so is insurance, this is a very specific product for someone on hormones who's using a generic estradiol patch. But yes, insurance is also covering, the gels are also generic. So things like Divigel, you can also get very affordably. So if you're just someone who prefers to take your estrogen, again, as we said, we think there are benefits to non-pill form, and you really would rather do, maybe you have an irritation from the patch, or you just like the idea of using the daily gel. It usually goes different products, but some go on your thighs every day. Yes, you can ask your healthcare professional for generic Divigel. I think estrogel is also generic. So let's see. Brain fog, I think we talked about a lot. I really encourage people mostly to focus on their sleep, but also things like stress. So we're going over, so if someone needs to leave, please do. But I'll share. Oh, thank you for putting the gateway to better, the pathway to better sleep in there. So I always like to share one of my favorite stories. So I happen to know through the Menopause Society, we'd been on the board together, this incredibly thoughtful psychologist who does a lot of research. And so a lot of research in cognition and menopause. She's Pauline Mackey. You can Google her stuff. She's pretty brilliant. And so I had this time where like I couldn't find my car in one of the MGH garages like way too many times over a few months. And it's a big garage. And so I said, Pauline, I am really worried. I'm clicking my car clicker and I'm trying to hear the beep, and this has happened too many times. The first thing she said to me is, don't panic. I don't think it's memory. I think it's attention. She said, what were you doing? What do you do when you leave your car? I'm like, well, I'm looking at my phone. I'm seeing if I'm late for work. I'm juggling my tea, grabbing my backpack. She said, you didn't forget where you parked. You never knew where you parked. So literally, thank you, Pauline. I think it's been 6 years. Literally, every time I get out of my car in the MGH garage, I think, everyone, or something silly. And I just stop for a moment. I don't look at my phone. I make sure my backpack and coat are on, and I'm just standing there. And I'm like, this is where you park today. Some people, if it's a park lot I don't know, I'll take a picture, I'll write it in my phone. So, as we get older, we may not be able to multitask quite as efficiently as we did before. So be good to yourself. Give yourself the attention you need to get the information in. And the greatest likelihood is you'll remember where you left your keys. So a personal story, but I still think Pauline, and it was very reassuring. So I think that's another thing to think about. If you're getting enough sleep, if you're trying to be attentive. I've had some patients at midlife diagnosed with ADHD. These are often at this age. I had a patient say, Dr. Shifren, I'm 52, and my 18-year-old is about to head off to college, and I was with her psychologist. We were doing an ADHD evaluation. She says, I think I have ADHD. So meaning we weren't screened, people our age, if a lot of people on this line are the same kind of midlife age I am. So, if you really think, whoa, I wonder if this brain fog isn't just menopause, but maybe I do just get formally screened, talk to your healthcare professional. So, but don't panic, and if someone is really concerned, I've had some patients who are like, Dr. Shifren, I have early dementia in my family. Something's wrong. I'm just not thinking the way I was. Don't just say it's menopause, talk to your healthcare professional about a formal cognitive evaluation. They're very expensive. You do need to have a reason, but they can be really helpful. Most of my patients, they're really reassuring, and then you have a baseline. But occasionally for some people, very rarely, especially people who have, a genetic tendency to dementia, you may want to take it more seriously. Let's see. I think we have gotten through most of them. Long-term birth control pills. So it's a great question. I want to reassure people, contraceptives during the reproductive years are incredibly safe. They are very healthy. They have lots of non-contraceptive benefits. They reduce ovarian cancer and endometrial cancer and anemia and cysts and pain. They can be terrific. So, and in general, we don't think of that as being anything that changes your clock once you get to 50 and you have, start hormones. The one benefit of birth control pills, we didn't talk much about treatments during perimenopause, but birth control pills in those 40s and early 50s for healthy people. If you have high blood pressure, you can't take them over 40. Heaven forbid you're a smoker. You shouldn't take them. Over 35. If you have risk factors for heart disease or stroke, you shouldn't be on birth control pills because they're 4 to 5 times the dose of menopausal hormone therapy. So it's a great question because it's a good time to talk about how menopausal hormone therapy is just giving you back the same doses your body made when you were younger. Birth control pill doses have to be much higher because they prevent you from ovulating. That's how they work. But they're really safe, terrific form of both contraception, and we have a lot of women in their mid-40s that come in with intermittent hot flashes, night sweats, irregular periods, go on birth control pills, do great, come off in their early 50s. So thank you for the question. I'm not sure you got a lot more than you asked for, but birth control pills are a great way to get through perimenopause. Oh, excessive hair growth on the face. Sometimes as we get older, people do start to notice more facial hair, but a lot of young people notice it too. I would usually say just speak with your healthcare professional, dermatologist, whatever works for you. Just keep it safe. Let's see. Oh, someone asked about exercise and weights. I'm sure the Blum Center probably has some really great people to talk to who know a lot more about exercise. I think the one piece of advice I give a lot of my midlife patients is stay active, whatever it is you enjoy. If you can get half an hour of activity every day, if it's walking with a friend, wow, you're also getting the wonderful boost you get from social interactions. If you love going to the gym, if you like classes at the gym, classes at home, it doesn't matter what it is. Try to shake it up a little. Don't do the same thing all the time. It's good to use different muscles and use your body in different ways, but just stay active. And don't forget the silly things. I mean, I really encourage people to do a step counter. I think our phones capture it for most of us. I used to put things at the bottom of the stairs for the laundry, and now I'm like, walk it up, throw it in the hamper, come back down. Oh, there's something else. It seems really silly, but I might get an extra 4 or 5 flights of steps a day instead of being efficient, but thinking, what, steps is my principal goal. You can get a lot more steps, the silly things, parking far away when you're at a mall, trying to walk places you might have driven. I have a few patients who take the subway to work, and you know what? If you can get off one stop earlier and get that 15-minute walk to work every day, of course, it depends where you work and where your subway lines are. You're getting 30 minutes every day without even thinking about it, right? So try to just build an activity in your day in addition to getting some committed exercise. So weights. So what I do recommend though is if there are some studies that building muscle mass is really healthy. It might prevent fractures when we fall, might be really good for weight maintenance, and it's very healthy. But you can hurt yourself because we also get more joint stuff and arthritis as we get older. So I typically say if you want to start something with weights, if you can afford it, this is the time to go to your local Y or gym and actually do a few sessions with a trainer. Let them know if you have arthritis of your shoulders, arthritis of your wrists or your knees or your hips. Let them know what things sometimes hurt you. Oh, my back hurts. And then have them work with you to develop a safe way to use weights because you can hurt yourself. But once you've got it, then you don't have to pay anymore. You purchase the equipment or weights or whatever it was that you worked with for home and just do it safely and don't do anything that hurts. I think we have covered most things. We've covered most of them and we should probably let people go. But hope this was helpful. A big thanks to the Blum Center for doing such a great job educating our patients about so many important topics. Please, again, use the menopause.org website, use the MGH Midlife website. There's really a lot of information out there for you.
Thank you so much, Dr. Shifren. As you can see in the chat, many thanks to you. This is extremely helpful. And thank you so much for taking the time to go over everyone's questions.
Absolute pleasure. Stay well. Take care.
Take care.
Bye-bye.
And for everyone joining us, thank you so much. I included all of the resources that were mentioned today, including Dr. Shifren's slides. Feel free to review the recording once that's up. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Take care.
Yeah, bye-bye.